Hi class, my name is Jada Stevenson and this is my presentation. First, I want to apologize because I have been fighting bronchitis and a really bad upper respiratory infection for like the past 2 weeks. So if I speak weird or cough or my voice cracks, I apologize. I can't help it. This is probably the best that I've sounded in the past 2 weeks, so just bear with me through that. But my presentation is on palliative care and pain management. How palliative care is different from other specialties. Palliative focuses on patients with life-threatening and life-limiting illness. Um, Typically, there's no cure, but treatment is still available if it helps with the quality of life. And the focus is to have, to maximize quality of life as much as possible. Palliative also is consists of a whole team of different specialties that address the biological, emotional, cognitive, social, cultural, and spiritual aspects. Um, Again, palliative focuses on the relief of chronic suffering and improvement of quality of life for patients, excuse me, with no cure for their illness. Suffering can be physical, psychosocial, and spiritual distress. Um, so palliative is also integrated with, you know, therapies that intend to prolong life. Um, it's not like the sole care for a patient. It's in a combination with like the primary team, um, and like the attending physicians and things like that. When therapies no longer work, palliative care adapts. Uh, by this, I mean that um, palliative care is there to help you to maximize your quality of life while you're living with this illness. Maybe it's MS, maybe it's diabetes, maybe it's cancer. I've seen people live with cancer for 10 years, didn't know that was possible, didn't know a lot. Actually, I should have mentioned that my field placement is with a supportive and palliative care team with a licensed clinical social worker on the team, and that's why I chose this. So learning a lot. So some of this I try not to go off on a tangent because I'm just talking about the knowledge that I've gained in my field. This is a picture that I found that is similar, kind of similar to what um, my field placement is like. Um, Palliative care is a consult team. There's the primary team, who are just like your bedside doctors, your attending physicians, your hospitalists, and then they will consult the palliative care team if they see a patient and they're appropriate, meaning there might be difficult family dynamics or they might need advanced care planning or help with the prognosis, explaining the prognosis to a family or a patient, or helping a family make difficult decisions, life support, different things like that. So you'll see that there's the general side and then there's the specialist, the consult team. At the hospital I'm working at, hospice is separate from palliative care. Hospices are like outside agencies that palliative care can send referrals to. And then we also have outpatient in the community palliative care, so that when patients do get discharged, they can follow up and receive report outside of the hospital, even though they're not inpatient, because in the hospital is inpatient, outside of the hospital is outpatient, as we already know. Some of the main challenges: under treatment of vulnerable populations, um, age, gender, race, ethnicity, socioeconomic status, language, substance abuse disorder. With the geriatric population, just to name some of them, can be cognitive impairment. They have dementia, pain, and depression, which correlate. Decrease in functional status, the ability to even like put your shoes on, um, and also just existential issues like the will to live. Older people may feel like, oh, this is just a part of it. This is to be expected with my age, and minimize their symptoms or their problems or their pain. So that's a vulnerable population. Also, gender, men and women experience pain differently. Brain chemistry, hormones, all of that kind of takes into effect. And also, women are taken less seriously as patients. patients, I'm sorry, minorities, race, ethnicity, socioeconomic status, all of this can affect how your treatment. Um, Less likely to receive adequate treatment. Poor communication, mistrust. We know that there's a lot of mistrust from patient to doctor um, based on these things. Health literacy, language. If you don't speak the same language as your health team, that can be very difficult. You can be undertreated. Something can be missed. It can be harder for you to express your needs. Uh, and then again, substance abuse. We know that there's an opioid epidemic. We know that pain meds are controlled substances. A lot of them are opioids and different things like that. That can all come. That also takes an effect on it. And then addiction, the tolerance. You can just become addicted. You're not trying to. You build a tolerance to it. You become dependent on it. Your body is using these things. So then that leads to something called pseudo addiction, which I just learned about from this class. Pseudo addiction is, I guess, when you have kind of like the characteristics of what an addict would have, but it's not your fault, and that can kind of affect uh, your treatment, when you're clocking your pain meds and clocking when your next dose is, and, but it's just that you don't want to be in pain. And I mean, they are addictive substances. That's what they are. And naturally, over time, your body is just biologically, you're just gonna become dependent on it. Um, Also, providers who give out these prescriptions, they also are afraid of scrutiny and consequences if they give too much, or the wrong the wrong medication, or they think about relapse. Also, there's a lack of time to get to know your patient like that, so that you can, with sorry, and there's it's time sensitive, so it's difficult. That's just a little bit of just the vulnerable populations. I could go on about that for like ever. Um, Coping with illness. This is something that I definitely see in my field placement. Um, the ability to not be able to accept death. They call it magical thinking. This could be a family member putting a patient through things that they shouldn't be going through, but just because they don't want to accept that there's nothing more that can be done, which is completely understandable, or the patient not being able to accept that there's nothing else that can be done, and that they should change their focus to comfort care. Also, it's hard for healthcare providers to have these difficult conversations, and that's why social workers are awesome, because whenever there's a situation like this, they call my field supervisor and they're like, can you help me with this family? Can you help me with this patient? Can you come to this family meeting? Because these conversations are difficult. But again, that's a big one. I see that all the time. A mom is pretty close to brain death, but her daughters don't want to give up, and they're like, there's one more procedure, there's one more surgery, there's one more thing that we can do, and they're her medical or her surrogate decision makers. So it's just hard. It's very, very hard, and which is completely understandable, but it is hard when you're having a hard time coping with illness, and that's why social work is awesome. Okay, I'm going on a tangent. Social work hasn't fully emerged is another issue. um I'll be honest, before my field placement, I had never heard of palliative care. I didn't know what it was. I didn't know anything about it. Now I love it so much, but I had no idea what it was. And, from reading our textbook and just from my personal life, there isn't a large presence of social workers in the field. There's one social worker on the palliative team that I'm following for my field placement. There's another social worker on the outside. There should be multiple social workers. There's multiple doctors. There's multiple nurses. There's multiple chaplains. There's multiple PAs, but there's one social worker. That just goes to show that social work presence it's getting better, but it's not there yet. Lack of adequate training. So palliative care could be a course in itself. And there's just a lot of social workers aren't exposed to this specialty or even know that it exists. Sorry. Also, in history, pain has been perceived as a physical problem. There wasn't really a biopsychosocial spiritual role. I feel like that's kind of new. Um, Also, it's hard for social workers in a hospital setting because of the shortened stays. And I want to say that there's kind of at the hospital I'm at, there's a difference between a palliative care social worker and a discharge planner. A discharge planner is like could be a social worker or a RN who does like the discharge planning and the case management, and they're go 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 go, and they don't have a lot of time to sit with their patients and do counseling and things like that. The social worker on the team I'm working with can. That's her job. Um, is more of the counseling and the clinical aspect. But it's still, if you have a caseload of like 15 something people, and hospitals, you're not in there for usually for a long time. It might be like a week or two. You don't have like the time. So that's another thing. How to prepare to address these challenges. The biopsychosocial spiritual assessment. Um, Assessing the whole person, not only taking into account their medical condition, but also their psychological, social, and spiritual needs. There is a mounting evidence that spirituality benefits pain. There's more optimism, higher levels of function, self-esteem, survival. There's higher rates of survival. Sense of a higher being. It's not just about God. It's also about nature, art, music, family, community. It provides a meaning and a purpose for life to keep you going. Um, so the assessment is huge. When you first walk into a patient's room and meet them, and all of this should be taken into account. Our assessment tools are probably different than other hospitals, but I know that that's what my field instructor does. She goes and she assesses the whole picture. She even looks at past medical history that might not even be related to this patient's stay, but she's teaching me to look at the whole picture and see what the needs are. And I think that that's one of the best things that you can do. Prepare for education and open communication. Again, the social work assessment. You don't want to just go in there. You want to be prepared. You want to assess and educate yourself on this person and the whole person, not just their medical diagnoses. Advocate for become an advocate for the role of social workers in palliative care and pain management. That's another way. Resources needed, social work knowledge and skills, understanding resources available, just working knowledge, understanding the difference between Medicare and Medicaid, spiritual support for grieving children, grief support, access to other resources, your assessment tools, you need a working knowledge, which takes time. I'm still learning about the different facilities that they have and what takes this type of insurance and this type of insurance, but it just, that is so important so that you can think quickly on your feet and outside of the box when there's a complicated or a complex case. Resources for patients, high quality communication. That's the good thing about palliative care. We communicate and coordinate. We get everybody on the same team. Everybody has and everyone's on the same page to provide the best care for the patient. Family meetings. Family meetings are like an open forum where all the disciplinaries come around and we all talk about a goal. It could be talking about prognosis. It could be talking about where you're going after, anticipatory guidance. Informed social workers have to think 3 steps ahead. And again, I said to familiarize yourself with charts. To prevent an issue, you have to think 3 steps ahead. And I see my field instructor do that. She's so amazing. She will think, okay, they'll come up with a plan. And she already knows this might not work for A, B, and C reasons. And here's our backup plan in case that happens. Patients also need, and I'm going to run out of time soon. I'm going to have to make a second video. But an extra layer of support for patients and families, advocacy, supportive counseling, education. Again, what I said, anticipatory guidance, guiding them. We can't make their decisions for them, but we can guide them, show them what this road looks like, what this road looks like, and what the third road looks like if they decide to take these actions. It's amazing. In advanced care planning, advanced directives.